Today on This Week Health.
If you take a step back and think about the progress that we've made in the ability to do a lot of things remote, and you couple that with the great resignation that's going on right now, where folks are walking and taking other jobs, I think if you don't offer that flexibility, you're probably dead in the water.
It's Newsday. My name is Bill Russell. I'm a former CIO for a 16-hospital system and creator of This Week Health, a channel dedicated to keeping health IT staff current and engaged. Special thanks to CrowdStrike, Proofpoint, ClearSense, Meditech, Cedars-Sinai Accelerator, TalkDesk, and DrFirst, who are our Newsday show sponsors for investing in our mission to develop the next generation of health leaders. All right, it's Newsday, and today Colin Banas joins me from DrFirst. Colin, welcome to the show.
Thank you, Bill. I'm so happy to be here.
This is going to be fun. We were just talking about what we were going to talk about, and we just threw up our hands and said, there's so many things to talk about. We're going to hit the news stories and see what's there. You're a physician. Well, first of all, tell me about DrFirst. It's interesting because somebody said, tell me what DrFirst does. And after I got done, they're like, Bill, that was not as succinct as I would have liked to hear from you. I don't have the succinct story. What is it that DrFirst does?
Yeah, I think to know what we are now, you have to know where we started. And so just the 2-second version is that we cut our teeth as an e-prescribing company way back in the year 2000, before EMRs were big, before e-prescribing was mandated, et cetera. And from an e-prescribing company blossomed into an innovative health IT company with a real strength in medication management. So a lot of our solutions center around making sure patients get on therapy, stay on therapy, can afford their therapy, as well as improving things like medication reconciliation, using some pretty interesting and patented technologies.
If I were to say that, does that encompass all the things you do, or have you branched off beyond that?
We continue to branch off, and I think that's probably what makes it difficult at times to describe. But within the last 5 years, we've also developed a care collaboration platform. We call it Backline. And of course, with the explosion of telehealth because of the pandemic, we had a lot of success in that as well. And so there's a myriad of solutions if you look at the entire portfolio. But I still consider medication management to be the core of the business.
Core of what you do. Cool. And your role is CMIO?
CMO, Chief Medical Officer.
Chief Medical Officer. All right. So let's start with this. This is right in your wheelhouse. Physicians in the same health system make vastly different choices for identical patients. This is from healthexec.com. And let me give you a couple of excerpts real quick. Physician practices in the same geographic area, vastly different levels of care during identical clinical situations, including some concerning variations according to new analysis. Clinical and policy experts assess care strategies used by more than 8,500 doctors across 5 municipal areas in the U.S., keying in on whether they utilize well-established evidence-based guidelines. They found significant differences between physicians, including some working in the same specialty and even the same hospital. In some of the cases we looked at, physicians who made the most clinically appropriate decisions were 5 to 10 times more likely to use the recommended standard of care than peers in the same specialties, and cities whose decisions tended to be the least appropriate. Lead author, ZIRUI, Zuru Song, MD, PhD, Associate Professor of Healthcare Policy and General Internist at Massachusetts General Hospital, said in a statement, the difference we found is a cause for concern. They go on, additionally, doctors were separated into 5 groups on how likely they were to abide and use guidelines, and patients with similar clinical and demographic traits were included. They did this based on information they collected. They also looked at claims data and a couple other things. Clinical variation. This is a challenge for a lot of health systems. Why is it a challenge, and where are we seeing progress in this area? I mean, this doesn't surprise you, does it?
Not at all. In fact, prior to joining DrFirst, I was the CMIO for a large academic health system. And one of the core things that I helped oversee was an entire program devoted to reducing unwanted clinical variation. My health system was VCU, so if you know anything about Virginia Commonwealth, their mascot is the Rams. And our program was called Ram Care because we were looking to reduce unwanted variation through a reliable, appropriate, and measurable care. And the idea was to get clinical consensus for some of these high variation conditions, whether it's surgeries, whether it's types of admissions. And then, and this is the key, and this is where I think there's still hope, hardwire that into every facet of the care, specifically into the EMR. And so I think coming from a CMIO role, we know that the EMR is a constant. It is the predictable thing that touches every patient, more or less. And so there are things that we can do within the EMR to hardwire appropriate behavior or reduce the likelihood of unwanted variation.
But don't you struggle with, don't tell me how to practice medicine? I've sat in those meetings and I've seen doctors look at each other and they're like, that's what you do? Where did you learn to practice medicine? I mean,
it's like herding cats. You said, why is this difficult? It's exactly that. Strong personalities and maybe even a little bit of ego. I'll tell you, the RamCare initiative was successful, not because of the technology, and you hear this all the time, but it was a commitment from the chair of whatever department that condition was applied to, and that chair was heading up the committee and then holding all of his doctors or the care team accountable to the things that we were measuring. And that's the other part, right? And where EMRs and big data come in. You can't manage what you can't measure. And so the fact that we have the ability to measure these things leads itself to an iterative improvement cycle. And so I do still think there's hope, but that article was pretty surprising. Well, not surprising, but pretty damning, if you will.
Yeah. What's interesting to me is I was in the Southern California market. Our health system saw a third of all patients in Orange County, California. But the other system that saw a third of all patients in Southern California was Kaiser. And when Kaiser first came into our market, their quality scores were far lower than ours. And we sort of scoffed at them, like, if you want really good care, you come to us. If you don't, you go to Kaiser. But over time, Kaiser's quality scores kept going up and up and up. And what they attributed to is a very prescriptive way of practicing medicine. If you work at Kaiser, it was evidence-based care guidelines. This is what you do. The EHR told you what to do at every step, and you were expected to follow that. And what was scoffed at initially became a very powerful mechanism for turning something into a very high quality system.
Yeah, this always gets into an interesting conversation about clinical decision support or CDS. And there are certain things, so in my opinion, and I think good CDS is like the lines on a highway. Keep me in the lines, help me go to the right place and do the right thing. But if I need to, as a clinician in the moment, if I need to deviate because of some particular reason, I'm not hardbound by those lines. I can cross over them in select instances. And so that's where you see a lot of pushback against things like interruptive alerts or hard stops. And you get more success with what I call the passive CDS, whether it's suggestions or visualizations or dashboards. And the idea of dashboards goes all the way back to that iterative measurement process in terms of leading to improvement.
And we're hearing that same thing around AI. I mean, AI is obviously a component of CDS when we talk about it. Read all the notes, go through them, look for the patterns, let me know the patterns, because I'm going to be examining this patient. And you know what? I have to examine 12 other patients this hour. So just bring the things I need to know to the forefront and let me practice is essentially what we hear a lot. And when you hear this, the practice of medicine is an art or a practice of medicine is a science, the answer is yes, isn't it? I mean, it really is both. And when I go to a doctor, I trust them to not just go, well, I'm just following this. I go A, B, C, D, but to look at it and go, you know, I'm doing A, B, C, D, but based on my experience, my knowledge, my training, the reading I did last week from an article, I'd like to do something a little different with you.
Yep. I think AI is wonderful at pattern recognition. I think that's a lot of the advances we've seen in AI really lend themselves to things like radiology interpretations, pathology, dermatology, because it's pattern recognition. And I think that's where AI has shown the most promise thus far. although you cover pretty much on a daily basis. The explosion of AI it's on the upward curve for sure.
We'll get back to our show in just a minute. I'd love to have you join us for our next webinar titled Owning Cloud in Your Organization, Understanding, Implementing, and Designing Your Hybrid Cloud Strategy. We're going to have experts from Sirius Healthcare, Cone Health, St. Luke's University Health Network, and they're going to walk us through the lessons they've learned in moving to the cloud and adopting a hybrid cloud strategy. But specifically, we're going to talk a lot about moving your EHR into Azure, which both of these health systems have done. Join us Thursday, February 24th. You can register now at go.thisweekhealth.com/cloud_webinar or by clicking on the registration link in the description below. Now, back to our show. Let's do this one. CIOs plan big investments in EHR optimization and pop health IT. Again, this is not shocking to anyone. We're going to optimize the EHR. Isn't the EHR optimized at this point? Some of these implementations, I'm looking at this list of CIOs. South Shore Health, you have Providence is in here, BJ Moore's in here, Ohio Health. I mean, these are established systems. Some of these have been on their EHR for a decade. Ascension's on here. That's a different case. They have a lot of different EHRs. Penn Medicine's on here. So again, not a massive health system, probably on a single EHR. We're still optimizing the EHR. I don't want to keep starting this with, does that surprise you? It sort of surprises me if after a decade, we're still optimizing the EHR. That would lead me to believe that we have inflexible software that we can't, or we have inflexible processes that we can't take the inefficiency out of. Am I not looking at this right?
I think, well, you are, but I think you can develop a lot of bad habits in a decade. In fact, it doesn't surprise me that the older implementations struggle. I think if you go back a decade, it was all about.
So this is like cleaning out my closet. You're
Yes.
saying I just keep throwing things at this, and the order sets gets messed up, and this gets messed up. I know there's governance around these things, but just over time, it's like, hey, it's time to clean this thing up. It's just got to be a mess.
Well, and back to my comment about the chairs heading up certain RAM care initiatives, you can have governance and then you can have good governance. And a lot of times people fold to the new specialist who demands a new care set or order set or a very specific form of a rule or alert for certain situations. And I would say over the course of a decade, like you mentioned, you can really accumulate some junk. In fact, especially if your EMR is highly configurable, you can almost paint yourself into a corner where you start to get into trouble with your ability to take new functionality or take upgrades from your core vendor. And I think what you saw from the larger vendors more recently is a push towards, call it whatever you will, model content or core content, where it's almost frowned upon, if not impossible, to deviate from certain core functionalities within the EMR. To some extent, the newer implementations have a leg up in terms of standardization and lessons learned.
It's interesting. And again, I'm not going to talk about specific EHRs, although everyone's going to know who I'm talking about here. But when the EHR provider is prescriptive, that's almost a backstop for me and my governance, right? So I can say, look, our EHR provider won't do that. They won't allow us to do that. There's a build that becomes the floor for how we can do certain things. I've often thought that that's really prescriptive, and I'm not sure I like it from a CIO perspective, but I can see why I would like it, because I have somebody else who's saying, no, it's not always me in the governance process saying we really shouldn't do that.
I couldn't agree more, actually. There's technological cover in terms of we can't do that or the technology won't allow it. And then there's also regulatory cover. I know you don't want to do MedRec, but it's probably a bad example because MedRec is highly important and saves lives, but it's a regulatory mandate that we need to do this and we're being measured on it. So I'm sorry that you don't think it applies, but it's not up to me. This is coming from a higher power. So you do get a little bit of cover in your CIO or CMIO role for things like that. So I do agree that it's not fun to use that as an excuse, but it is welcome sometimes.
What's the best governance you've seen? You can choose any area. I mean, it can be around a specific thing. It can be around an EHR implementation or whatever. I'm going to tell you what mine was, and you're going to scoff at me, but I'm curious what ones that you've seen that you said, hey, that governance that worked, and what were the elements of that?
So we had an entire governance structure around ED diversion. So our health system was super busy, and going on diversion, of course, is not only financially bad, for lack of a better word, but we also can't treat our population. We can't serve our mission. And so this was a top-down governance. The CMO showed up at every meeting and got commitment from every single department within the health system, all the way down to the folks that help turn the beds over and transport, because every single piece of the care continuum had an element that they could control and that they could improve, and that we could turn that ED diversion time around. And it took years, but it was consistent, it was dogged, and back to my earlier comment, it was measured. It was measured at every level, at every department, all the way down to the individual shift. But it started with our CMO, and he was a charismatic guy, and we could all get behind him.
Executive buy-in. We hear that word, executive buy-in, all the time. But when you have governance meetings that don't have activity, don't have action, don't have value, the executives, they scatter because they have other work to do. There's a lot of important things to do in healthcare. And some of the best governance I've seen is where it is just 5 people, 3 people. And essentially they're bringing the things in, they're making a decision. It always has to be an odd number, by the way. It cannot be an even number. Otherwise you're going to get to an impasse. But there's sort of an agreed on decision-making process. You're trying to let the organization make the decisions, but the governance is there to make sure that the guidelines are in place, and then you keep progress. And I've seen it a couple places. And at first I thought, when somebody told me, hey, this is what we've done, I thought, man, that's not replicable. And then I've heard it in a couple other places, and I thought, that's interesting that seems to be a model that works. Because I've been in meetings, governance meetings, that had 16 people at a table going, should we move forward with this project? Everyone, and I go, man, 16 people think we should move forward with that project. I find that hard to believe. And I'm walking out and I say to somebody, why'd you vote for that project? It's like, because I'm bringing my project next week.
Yeah.
I'm like, oh man,
I've definitely experienced that. It often presented itself, just like your example, in terms of IT roadmap. If you're not very specific about your 12-month run out in terms of what you can and cannot accomplish, you'll keep adding things to the roadmap, and you'll dilute the effort. And of course, none of them will get done. And so we eventually got to a point where we said, okay, if we're going to introduce something new, this group is going to tell us what we're going to take back off, because we can't continue to do it all. So I think it's a perfect example.
So the next thing they talk about is big investments in EHR optimization and population health IT. Population health, it's always been one of my favorite terms, because if I went into a health system and told them, you're going to have a pop quiz today, and it's going to be on pop health, and it's going to be a 1-question quiz, and if everybody gets the same answer, we're going to deem this as a success. And we're going to say, what is the definition of population health within the health system? Unless it's very focused, the answer to that is going to be all over the board. And I used to love that, because they'd come to me as an IT person and say, put these foundational elements in for population health. And every time you sort of pushed on it, it got a little squishy. So yeah, we need analytics, and we need analytics beyond just the EHR. We need analytics on the community. And yeah, we need interoperability, but we need interoperability beyond the clinically integrated network. We need interoperability to these other entities who are delivering social services and other care services and other things to that effect. And it seemed like population health didn't have like 4 walls to it. It seemed like it was nebulous. And from an IT standpoint, that always concerned me, because it was a project. There was always another project waiting to happen within it with not a lot of definition. Do you have a great definition for population health?
No, I think you're spot on that it can be incredibly squishy. I think successful pop health programs do it in the cadence of people, process, then technology, and aligning those people around a common problem that they want to solve. And so for an academic health system, for example, it could be the chronic folks who are getting readmitted, who are indigent, and so we're on the hook for them no matter what. and then identifying that population and then putting the resources and eventually the technology around it to tightly manage that population to a predetermined goal, which is in this case, reducing readmissions, and then secondary benefits of things like demonstrating improvements in blood pressure, hemoglobin A1C, cholesterol, things like that. And so I think, and you've said it 1,000 times, people rush to the technology very, very early, when really that probably should be the last thing that you should be evaluating when trying to stand up a pop health program. You know, at DrFirst, the piece of the pie that we have in pop health is around medication adherence. And so that is a piece of the puzzle that we try to bring in. And I think you said it beautifully in terms of outside of your core EMR, outside of your clinically integrated network, where am I getting additional data that I can bring in these insights that I can then empower that clinical team to make interventions to get patients back on therapy. And so that's the piece of the puzzle that we're really proud to own and that we're trying to push really hard in this year upcoming.
What I've seen more often than not is that population health programs support the value-based initiatives, right? So if a health system is a payer provider, which we're seeing more and more, you'll see a lot more focus on population health initiatives. And it depends what umbrella it comes under, but essentially the model to support it is the value-based care model, or where you're taking on risk for a population. And in that population, we've moved from sick care to well care. Love to see that happen more and more. Love to see us take response. You talk about med adherence and those kind of things, number of prescriptions that go unfilled. Do you know the percentage off the top of your head?
It's 25% of new prescriptions go abandoned.
And we don't really have the number of, because we just don't know if people take the medications and how much ends up in the medicine cabinet. I don't know. Our technology is getting better at that.
Yeah, I think there's certain things that we can do. You think about all the different places where adherence can go wrong. One of the things that we strive to do at DrFirst is patient engagement immediately after the prescription has gone out into the ether. The abandonment rate is 25%, really boils down to three big friction points. One, cost, right? So we know that if the copay is $50 or more, the likelihood to abandon goes way up. Number two, lack of understanding or education or misunderstanding about side effects. And then the third one is people just forget. I know I forget. I rely on reminders either from the EMR, from the pharmacy dispense to let me know. And so we have technologies that engage the patient immediately after prescriptions go out the door via text. We're not going to rely on the portal. We're not going to rely on a new login or a new app for them to go get. We're going to do it via text because the research shows over 93% of texts are looked at and responded to. And then we deliver an app-like experience, and we serve up coupons or copay assist when we've gone out into the ether and matched it up. And we also provide videos and educational content, and even give the ability to schedule reminders within your smartphone. So that's just one piece of it, right? Because now you got home, and to your point, the prescription's in the medicine cabinet. How do I know you're taking it? And that's where you've seen other technologies, smart caps on pill bottles, reminders, smart assistants in the form of your Alexa to remind you to take your medication.
Sorry, I didn't have the group with the
So Alexa is listening to us right now.
Yeah, so and all the way to refills. How can I make sure that you get your refills on time? How can I engage you either with a chat bot or with a pharmacist or someone from the clinical side to check in to make sure you're staying adherent? So there's all different touch points that we can conceive. And again, I think it takes a village in terms of technology in order to achieve that perfect adherence.
I start thinking about ubiquitous technologies, ubiquitous interfaces, and texting is probably the most ubiquitous interface. Everyone does it. My mom does it. My dad does. Well, my dad does it on his iPad, but he does it. It's like passing notes in grade school, right? I mean, everybody knows how to respond to one and how to whatever. I mean, the other is the web. Everybody knows how to get on the web now, even if it's to check sports scores. or in my father-in-law's case, to check the obituaries because he wanted to see if any of his friends died. I mean, the number of times he got on the internet, it wasn't often, but that's what he did. But he knew how to get around. He'd click on things and whatever. Those are ubiquitous technologies. But the sisters, I was at a Catholic health system, and the sisters used to always challenge me to think about the underserved. And I would say, well, everybody can respond to text. And they'd say, not everybody has a phone. And we just learned through the pandemic that not everybody has a computer, because we're in the tech world. How do we solve that problem? I mean, do we solve that problem just by continuing to support programs that get tech into people's hands?
Yeah, I think that's the role for the social services, those pushes to get broadband into underserved areas. We saw a lot of legislation trying to promote that when the pandemic hit. And then there's even new technologies like Starlink.
I'm looking forward to that kind of satellite-based technologies addressing the latency problem. I think that's why we haven't seen it rolled out across the board yet. They're still trying to work out the latency. But man, if they could ever work out that latency, we now could cover the globe with pretty cost-effective internet. That would be pretty interesting.
Yeah, and I think that's the vision. And I think to your earlier comment, I think smartphone access is becoming more and more ubiquitous. Yes, there are definitely folks who don't have or cannot afford, but the price points keep coming down. The technology keeps getting better. And you can do a whole lot from your mobile device in this day and age.
I want to talk return to work. The reason I want to talk return to work is we had a very dynamic conversation with 13 CIOs that I was meeting with this past weekend around return to work. The ideas and the concepts are the same around certain aspects. Like, we know that people want flexibility. People want a choice now. It used to be we could tell them, hey, you're coming into the office. In fact, somebody shared a story that a health system in New Jersey went full on, everybody's coming back to the office, 100%. And they immediately lost 10% of their IT staff because people want flexibility. And so people are trying to juggle this return to work. One health system sold $50 million worth of real estate that was their IT building. And they said, we are now 100% remote. And then they had the challenge of some people still wanted to go somewhere. And so they're solving that specific problem. And other health systems are just now starting to say, okay, pandemic's starting to wane. Omicron has either inoculated or gotten a majority to get vaccinated, and we're ready to come back into the office. And they're trying to do this hybrid thing of 2 days, and not even saying 2 days a week, we're all going to be here Tuesday, Thursday, but just saying 2 days a week, you pick the day. There's a lot of flexibility involved there. What are you seeing, and what do you think would work as a former leader in a health system?
Well, it's interesting. I'm in the minority. I miss the office terribly. Something about the energy of others and the sort of the random interactions and the chance for, I just miss people. And so I'm hopeful for some semblance of getting back into the office. But what you just laid out rings true even for our own company. We got rid of a whole bunch of our office space. And in fact, the remainder of the space is converted into that shared space. Lots of table, hardly any more cubicles, hardly any individual offices, a couple if you need to make private phone calls and things like that, but a lot of shared space, a lot of whiteboards. I'm a little different. One, from a clinical perspective, the clinicians really didn't have a choice. They were suiting up, going in every day. And as a former CMIO, IT is there to support the enterprise and to support the clinical enterprise. And to that extent, there really does need to be an in-person presence, at least of some skeleton crew at a health system, whether wires and fibers and things like that. But if you take a step back and think about the progress that we've made in the ability to do a lot of things remote, and you couple that with the great resignation that's going on right now, where folks are walking and taking other jobs, I think if you don't offer that flexibility, and in fact, I've heard you talk about companies that are making sure that they can recruit across all 50 states now, because if they can't, they're not going to be able to staff up. So I think if you don't offer that flexibility, you're probably dead in the water.
One of the CIOs I was talking to, 48 state hiring strategy, And he said the return to work is going to be the biggest boom to his recruiting that he is doing. Because he's like, look, if every health system across the country loses 10% of their people as they try to bring them back into the office, that means there's a bunch of them looking for jobs. A lot of them are going to have experience in the EHR that he was on, or the analytics platform that they're on. They're going to have migration experience. They're going to have, he goes, so a lot of good people are going to say, I like the autonomy, I guess, and the flexibility. I'm with you, by the way. I do miss people a fair amount. Of course, I have my own business, so I made my own bed. I'm lying in it, which is, if you're not going to work for a large company, that interaction is not going to be there anyway. One of the things I did throw out to them was around culture and getting people committed to the organization and the mission of the organization. And as I think about this, let's assume you work for me and I'm talking to you and I feel like things are good and that kind of stuff. And then you hang up this Zoom call, and the next call you have is with a recruiter who says, Colin, doesn't this feel a little stale to you talking to me over this thing? Wouldn't you rather be at an organization that blah, blah, fill in the blank? I'm like, aren't you concerned as CIOs that your people literally could start working tomorrow for a different company and just a different Microsoft Teams meeting or a Zoom meeting, and they're doing the same work that they were doing before? And they are concerned about it. It is a concern. They've spent a lot of time working with their managers to help their managers to understand that their relationship, their one-on-one Teams meetings or Zoom meetings are really important at this point. Just because you've been on group calls with these people all day doesn't mean you've made that connection that you need to make with each individual in your group to ensure that they understand their career path, they understand the mission, they're connected to the mission, they're happy with things, they're still happy with working at home. Somebody might have moved. Gosh, the stories are just amazing to me. The number of people who moved during the pandemic and didn't let anyone know is kind of interesting. And how people found out is also kind of interesting. People just assumed, hey, I don't have to go into the office and we're on a Zoom call. I could do this from anywhere. You want to riff on any of that stuff I just threw out there?
I have direct reports that I've still never met in person. 2 years of working together. Of course, we see each other every day. We try to turn the cameras on. I think that's important at a minimum, but I think you're right. Nothing beats the in-person experience and the camaraderie. I really miss the camaraderie. We've had 2 holiday parties now that were Zoom parties, as opposed to that predictable time where the entire company was together. And I miss that. But times have changed. And if you're not offering that flexibility that you referred to earlier, people are voting with their feet. And you're spot on. If you do not develop a good culture, good camaraderie, one-on-one touch points with these folks that you were getting previously in the office, yeah, those are the folks that are likely to be lured away. And right now it's dog eat dog out there in terms of recruiting and retaining talent.
It really is. We're going to do one story, and then I'm going to ask you your plans for HIMSS and Vive, because I want to get the read on this 2 weeks before the actual conference. The last story I want to cover is Senators intro bipartisan effort towards modernizing health privacy laws. This is a long time coming, isn't it?
Yeah, this one was interesting. They're trying to stand up a commission to make recommendations, essentially revamping HIPAA, from what I can tell. And yes, it is a long time coming, of course. Interesting aside, one of my favorite Twitter that I follow is Bad HIPAA Takes. I don't know if you've ever looked at that, Bill, but
no, that would be fun.
There's a lot of people out there who are misinterpreting HIPAA. And when this guy gets a hold of them, he puts it on Twitter, and it's a laugh riot. But I'm interested in your take on what we read.
Excited about it. As I think about it, I think waterfall versus agile. Right. So one of the things that happened with HIPAA is it needed to be updated like on a every 6-month basis. And instead it became sort of it's the law, it's bedrock and that kind of stuff. And then people implemented it and the world changed. Since HIPAA was passed, when was HIPAA passed? It was in the 90s. The world's changed in the last 20 plus years. And the things that marketers do today in terms of tracking you and all that other stuff and whatnot are completely different. The movement of this data into Apple Health, into other things, the world has changed. So I'm glad they took this up. I think this is a long time coming, but I would like something that sort of gives them the ability to monitor it, change it, continue to adapt it. Because if the smartest people in the world put something in place today, it's in this tech world that we live in this mobile world we live in this data hungry world we live in, that whole thing is going to change in 6 months.
Yeah, one of the comments on the article, and it stuck with me, is the focus of any new legislation around this topic really needs to be on consent and control. And I like that. So the patient's ability to consent to the sharing of their data, even anonymized, which was another topic that this article took up. And then the ability to control where that data goes, all the way back to the individual patient level. It's a fine balance, though, because there's a lot of insights, medical breakthroughs, pharmaceutical breakthroughs that have occurred from the mining of anonymized clinical data.
I agree with that. I like the consent aspect of it. I've talked about Truveta and other things. IBM has a bunch of my data. Truveta has a bunch of my data. And I never consented to that data being used. Now, I know it's being used. Let me rephrase this. I believe it's being used well for the good of mankind. But I would have liked to have that choice. And I don't think if you gave me the choice that healthcare would be at a loss for research data. Because if you said to me, hey, Bill, you want to give your data to doing heart research studies around the world? Absolutely. A number of people in my family have died from heart-related issues. I would absolutely love to provide my data for that, and I'll do that for free. Somebody else might come to me and say, hey, we want to do studies around this, and we'll give you a free hot dog. And I'm like, yeah, for a hot dog, I'll give you my access to my data, that kind of stuff. Some stuff I'll give away for free. Some stuff you might have to incent me. Hot dog's probably not going to do it, but you get the idea. I mean, there are people that are like, look, if there's value in my medical record, I want that value to accrue to me. I want to be able to sell it. If somebody finds value in it, I want to be able to sell it. So I love that construct. The other thing people talked about, by the way, is, let's see, Teladoc, IBM, Epic, and athenahealth all signed on to support the proposed legislation. And the more cynical of us said, isn't that special? Like,
some of the biggest names in potentially profiting off of big data is,
yeah. Yeah, they want to be pretty close to this as it sort of winds through. That's what the cynical people are saying. But where I sit, if I were the CEO of Epic, IBM, who has a large data store, Teladoc, who's heavily invested, or athenahealth, I would absolutely, first of all, I'd absolutely support this because the ambiguity makes their role in healthcare harder. I would also want to be close to it because it's something you need to understand. That each of these companies handles healthcare data. All right, conferences. Are you going to Vive?
I am going to Vive. I will be in Miami.
Are you going to him?
Yep. A week later, I'm turning around, coming right back to Orlando.
We might be some of the few who are going to both. I will be going to both. What are you hoping to get out of each conference?
Well, this will be the first year for Vive, obviously. I found that when I've attended health or HLTH and Chime in the past, it's more about curating and developing potential partnerships between other companies. Where are the synergies? How could we partner up and solve some of these problems that we've been talking about for the last hour? When I go to HIMSS, I inevitably run into a lot of colleagues, whether they are CMIOs from my former life, CIOs that I've interacted with previously. And then, of course, there's also the bigger vendor touch points in terms of, back in my former days, making time to go see my core EMR vendor and do a touch base there. It's certainly interesting now that I'm on, quote unquote, this side of the fence in terms of how I view these conferences now. I definitely have a different appreciation now, having lived in both sets of shoes.
Yeah, some of the people I've talked to are kind of miffed. They're like, I can't believe they're doing back-to-back conferences. I can't believe that. And I'm like, well, they're competitors, and who do you want to back down? I mean, who do you want to say, oh no, you can have this time slot? It's actually a great time slot. There's a reason that HIMSS has been at this time slot every year. It's at the beginning of the year, so you can connect with all your vendors and whatnot. That's what I used to use HIMSS for. I mean, for me, it was one trip, and I got to explore new vendors, and I got to talk to my existing vendors. And because HIMSS and Chime were connected, I also got to see all my peers and get some new thinking, some new ideas, brainstorm around things, and develop my network. I sort of liked how that worked. I think that's the vision for Vive, is that you'll still have that. And I think they would like to, see HIMSS go away, is I think their goal and hope. And HIMSS is just trying to continue to be HIMSS. Do you think non-Chime members will still choose to go to HIMSS?
Non-Chime member, I think so. I wonder if the play and the expectation is, hey, C-suite, you're going to want to come to Vive, and hey, IT team, and maybe not quite the CIO level, we're going to bring you into HIMSS. It'll be interesting how it plays out. I also think attendance will probably be down for both, just based on the current state of events. Even if the pandemic is flaming out, I still think a lot of my colleagues and companies have pretty severe restrictions on travel. So it will be interesting, to say the least.
Yes. Well, and that's the other thing. As a physician, I was looking at their health policies, and the health policies are interesting because in the state of Florida, they can't require vaccine mandate as a requirement for admission. So they have policies that essentially say, look, show us you're vaccinated and gain admission. But the alternative is show us a daily test and you gain admission.
Yep.
And so there's different ways you can get in. I think the combination of things, though, if I were a betting man, the attendance at these things are going to be less than 10,000, which that's a bold prediction for HIMSS. It's not so much a bold prediction for a new conference. I think the Vive conference will come out of this looking better than the HIMSS conference, because HIMSS numbers will be down significantly from previous years. The Vive conference will look like a fairly good start, if you will, but it's still not going to be a big conference. It'll be 3,000 to 4,000 person conference, which is enough to have a conference if you have good content, good presenters. And I think both are doing digital content as well. So
yep.
We'll have to see how it plays out. Colin, I want to thank you for your time.
I love this. Anytime you need me, Bill, I'm here.
And I'm looking forward to seeing you in person. So we'll both of us will get our fix of people at the conferences that are coming up. So looking forward to that.
Thank you so much for having me.
What a great discussion. If you know of someone that might benefit from our channel from these kinds of discussions, please forward them a note, perhaps your team, your staff. I know if I were a CIO today, I would have every one of my team members listening to a show just like this one. It's conference level value every week. They can subscribe on our website, thisweekhealth.com. They can also subscribe wherever they listen to podcasts, Apple, Google, Overcast. You get the picture. We are everywhere. Go ahead, subscribe today. We want to thank our Newsday sponsors who are investing in our mission to develop the next generation of health leaders. Those are CrowdStrike, Proofpoint, ClearSense, Meditech, Cedars-Sinai Accelerator, TalkDesk, and DrFirst. Thanks for listening. That's all for now.